Now is the most opportune time for them to lean into education and preparation. Everyone, including their providers, to their coders, to their CDI teams, really need to understand the significant changes that's coming in right now with version 28, and to make sure that, again, that their coding and documentation is being aligned with that version 28. So right now they have the perfect window to review current documentation habits and identify any of those gaps before we get into 2026.
Welcome to the Move to Value podcast, powered by Chess Health Solutions. In this episode, we dive into the upcoming transition to CMS-HCC version 28, what it means, why it matters, and how providers can prepare. Our guest, TaSonya Hughes, Condition Management and Documentation Manager at Chess, shares expert insight on improving documentation, supporting coding accuracy, and navigating the evolving world of value-based care. TaSonya, to start us off, can you give a high-level overview of what the CMS-HCC coding model is and why it matters in healthcare today?
Yes, so the CMS-HCC coding model, which also stands for hierarchical condition categories, is really about helping Medicare understand how complex a patient's healthcare needs are. So it groups together those certain chronic conditions that typically cost more to manage over time, for instance, like diabetes or congestive heart failure. This model helps make sure the providers who care for those sicker patients are reimbursed more fairly. For example, if your patient has both diabetes and chronic kidney disease, their care is going to cost more to take care of those patients with those diseases versus someone that doesn't have those conditions. So the HCC model actually reflects that complexity, so providers aren't financially penalized for caring for those sicker patients. It's a key part of how value-based care works, tying payment to the patient's risk, not just how many visits or tests that the provider does for those patients.
Well, what prompted the shift from this HCC version 24 to the version 28, and why is this change significant for providers?
So the shift from version 24 to version 28 is more about improving accuracy and better capturing the true complexity for those sicker patients. Like for the providers, this means the codes are getting more specific, so our documentation must be as detailed to support those changes. Take, for instance, peripheral vascular disease, or PVD, for example. In version 28, now it's categorized more precisely based on the factors like, do they have ulcers or do they have a gangrene? That shift actually allows for a clearer picture of the patient's actual condition and the level of care it's going to take for that patient. So overall, version 28 helps ensure that the sicker, more complex patients are more appropriately represented, both clinically and financially, within that version 28 model.
So it gives a better picture, a more detailed picture of the patient.
It does. Yes.
So how does version 28 improve on version 24 in terms of capturing patient complexity and chronic conditions?
So one of the big improvements for version 28 is how it captures patient complexity in a more clinically accurate way. So compared to version 24, version 28 is much more focused on specificity. This means it does a better job of reflecting on how serious or advanced a condition actually is. As I used PVD earlier, so PVD, a lot of providers use peripheral vascular disease unspecified a lot of times. Now with the version 28, they have to specify in their documentation, does it have gangrene or do they have an ulcer? Because that's where the severity comes in. So they have to document that severity, whereas peripheral vascular disease now does not risk adjust or is attached to that HCC model 28 anymore. So again, it goes back to specificity when it comes to the documentation and the coding.
That's interesting. So what are some of the key changes in disease classifications or coding categories that have been introduced in version 28?
Now, that's one of the biggest shifts. So with version 24, there were like 86 HCC categories. Now, under version 28, we have 115 disease categories. That alone shows how much more detailed and specific this model has become. There were also over like 2,000 diagnosis codes that were removed from the HCC model, while only just 200 were newly added. So the significant change, this is especially when you consider some of the familiar codes that we used to use, what we used to call the low-hanging fruit, such as peripheral vascular disease or atherosclerosis of the aorta, like those no longer maps to the HCC category version 28, which they used to in the version 24.
How will the phased implementation occurring between 2024 through 2026 impact how providers report and document conditions?
So the phased implementation, which we also know as the blended model, which is what we're in right now, it started in 2023. So this will affect providers by allowing them time to make sure their documentation is aligned with the version 28 model, because again, it is more specific. So the documentation has to support those more specific codes. So providers now have time to look at those opportunities that they have with the documentation and to make sure that their documentation is in alignment for version 28 and those more specific codes. As of 2026, we will be 100% in the version 28 model. And at that time, it will be 100% providers' documentation has to align with that version 28 model. So right now, they actually have time to look at their opportunities that they have for that.
Well, what steps should healthcare organizations be taking now to prepare for full implementation of version 28 in 2026?
Now is the most opportune time for them to lean into education and preparation. Everyone, including their providers, to their coders, to their CDI teams, really need to understand the significant changes that's coming in right now with version 28, and to make sure that, again, that their coding and documentation is being aligned with that version 28. So right now they have the perfect window to review current documentation habits and identify any of those gaps, right? And making sure that their diagnoses and documentation are aligned together and they're very specific, making sure that the language in their charts are supporting those new HCC categories. Those are the kind of questions that they really need to be asking themselves right now before we get into 2026. They should be updating their training materials, offering targeted provider education. Running internal audits is very important to make sure that they can improve on their documentation with that. So it's really going to be like a team approach, as well as reaching out to me, their CHEST CMD manager for coding and documentation education, because that's what we're here for, to help them transition over into this version 28 model.
So are there specific challenges or pain points that you anticipate providers may face during this transition?
Yes. So honestly, being an educator for as long as I have, for about 10 years, providers do tend to struggle already with the documentation. So the transition to version 28 with this higher level of specificity could definitely feel like an added burden. But it's easy to see how this may come across as that, but it's really not. It's really just making sure the documentation is specific and aligns with the codes that are being used from the version 28 model. It's really not about doing more. It's just adding to what you're already doing. Providers are already doing the work. It's just about them putting it on in their documentation, everything that they're doing and seeing and diagnosing the patients with, those complex patients.
What role does accurate coding play in supporting value-based care and financial sustainability for providers?
So accurate coding and documentation really are the foundation of value-based care. So when our providers clearly document each chronic condition that the patient has, CMS uses that information in the background to calculate the patient's risk score. The patient's risk score shows how sick the patient really is with all of their chronic conditions. So if those diagnoses are missing, if they're too vague, then the true complexity is not captured for how sick that patient is. So then if we're not capturing that true complexity, then that's going to trickle down to the quality of care for our patients, as well as the financial reimbursement that it takes to take care of those patients. That financial reimbursement will also go into different resources for those patients. So the coding and documentation is the main piece to tell CMS really how sick our patients are. And if we don't, then again, it's like our patients could be likened unto a checkbook. So if we get the money that it takes from CMS to take care of the sicker patients, but we're not documenting and coding correctly, then now we're in the negative for our sicker patients, and we don't have those funds to take care of those patients when the time comes.
Well, how does HCC V28 or version 28 align with the broader shift towards value-based care and improved patient outcomes?
So the HCC version 28 really aligns with the broader shift towards value-based care by putting the focus where it belongs, on the quality of care for each of our individual patients, right? By accurately capturing a patient's full clinical complexity, this allows the healthcare system to better understand what resources are needed to support that care. So as I stated before, if we're not capturing that total picture of the complexity of the patient's conditions, then we're not getting the proper reimbursement back for those patients to truly care for them. So then that goes into, again, it trickled down to the quality of care for the patient, because we wouldn't then have the resources.
So beyond compliance and reimbursement, what are the potential benefits of version 28 for care coordination or population health management?
So this really helps strengthen care coordination, population health management, when the patient complexity is documented more accurately. It allows care teams, including providers, the care managers, the care coordinators, to see the full picture, and therefore the level of insight supports better care planning and helps ensure patients don't fall through the cracks, especially those with multiple chronic conditions, because again, those are our sicker patients. So from a population health perspective, version 28 gives healthcare systems better data to identify trends, stratify risk, even target interventions for those high need patients. Instead of a one-size-fits-all approach, we're able to focus on what the patients really need for each patient as individuals.
Well, tell me, TaSonya, what resources or support are available to help providers and organizations adopt V28 effectively?
So there are actually several resources out there to help providers and organizations navigate through the transition effectively. We have educational tools like webinars, workshops, continuing education resources, especially those led by experienced HCC educators like myself. We also have chart reviews and internal audits that are definitely powerful tools. I know a lot of times providers look at those as being negative, but when it comes from a place of partnership, then chart reviews and internal audits are really used as feedback opportunities so that it can help providers see where those opportunities are for them to better their documentation and coding.
How do you see the role of risk adjustment evolving as healthcare continues to move toward more patient-centered, value-driven models?
Honestly, I believe risk adjustment is going to keep evolving. I've been saying this for a long time. I've been in risk adjustment probably since the beginning of my coding career. So I feel like healthcare systems will have to stay flexible and proactive to definitely keep up with it. It won't be enough just to implement changes once and move on, because as we can see, coding and documentation, value-based, these models, they will continue to evolve. So I really think it's going to keep becoming more patient-centered, not just in theory, but in practice. It's going to be very important to take care of the patient through quality of care, through documentation, through coding, painting the full picture of what's really going on with those patients. Because again, at the end of the day, it is about the quality of care of the patient, and that's where value-based care is. And again, I don't see it going anywhere. I just see it's going to continue to grow and become more specific and evolve into something bigger for the patient.
Well, TaSonya, is there anything during our conversation today that I failed to ask that you think would be important for our listeners to know?
No, I don't think you've left out anything. Again, I appreciate you having me on here. The only thing I want to leave with providers is documentation is key. It's very important. Specificity is not going anywhere. Version 28 is about specificity. And if you have any questions at all, feel free to reach out to me. I'm happy to answer any questions when it comes to value-based care or the version 28 transition model.
TaSonya Hughes, thank you for joining us today on the Move to Value podcast.
Thank you so much for having me. I appreciate you.
This has been the Move to Value podcast, powered by Chess Health Solutions. We hope you enjoyed the conversation. To explore this episode further or check out past episodes and resources, head over to movetovaluepodcast.com. While you're there, you can sign up for email updates so you never miss an episode. If you're enjoying the podcast, be sure to subscribe on your favorite platform and consider sharing it with your network and leaving us a rating or review. Thanks for listening.